Welcome. My name is Debbie Doyle. I am the meetings manager here at the American Historical Association. Thank you for attending History and Historians in response to COVID-19 containing Contagion, which is part of the AHA Colloquium series of virtual AHA. We're excited to have you join us and are looking forward to a productive discussion. I would like to thank our generous sponsors, the National Endowment for the Humanities, the Stanton Foundation, the History Channel, and Oxford University Press. I also want to draw your attention to an AHA resource that might be of interest, which is the Historian's Response to COVID-19, a professionally vetted bibliography of responses to the pandemic, which was supported by a grant from the NEH CARES Act. I will post a link to that resource in the chat. I also wanted to let people know that we have another webinar in this series coming up next Wednesday on infection and inequality. You can find more information about that on the virtual AHA website. You can support virtual AHA and other AHA activities by joining the AHA, or if you're already a member, making a donation today. We will post links with details in the chat at the end of the webinar. A few logistical things to cover before we get started. By registering for or participating in the AHA's webinars, participants and panelists agree to abide by the AHA's Code of Professional Conduct. All participants will be muted, and you can use the Q&A function to submit questions to the presenters. We hope to address all relevant questions, but do need to be mindful of the time. The chair may paraphrase or combine questions if that seems advisable. If you'd like to be part of the conversation on social media, remember to use the virtual AHA hashtag. Finally, a quick reminder that this webinar is being recorded, and we'll share the recording on our YouTube channel soon. With that, I will turn the conversation over to the chair of the session, Keith Wailoo. Thank you.
Thanks, Debbie-Ann. Welcome everyone to this virtual AHA panel focused on not just history and historians responding to COVID-19, but the specific topic of contagion and containment. My name is Keith Wailoo. I'm the professor of history at Princeton, where I'm jointly appointed in history of science, and the School of Public and International Affairs. I will be moderating this discussion. A very brief word about what I do. I'm a historian of medicine and public health with a longstanding interest in the intersection of science, medicine, culture, and politics in the history of disease. This is one of several AHA virtual panels where historians respond to COVID-19. And as Debbie-Ann just did, I'll remind you of next week's December 3rd, there will be another 1.5 hour long discussion focused on the theme of infection and inequality, where I'll be a panelist. Now, in my view, the overarching question for today's session, today's discussion, contagion and containment, is how do each of our panelists understand the challenge of containing or eliminating infectious disease? And what are the most salient challenges and issues historians have explored in the past, and also as they relate to the novel coronavirus challenge, the challenges posed by the novel coronavirus in 2020 and 2021? To my mind, every avenue for containing contagion has been culturally contentious and politically fraught, with some successes, numerous failures, whether it's ghettoizing populations or quarantine, the closing of ports or the stoppage of commerce, the debates about masking, which have often been contentious, for instance, 100 years ago during the flu pandemic, including the topic of vaccines. Across the world, we've seen today and historically different uses of state power to contain the coronavirus, with much being made of the political and cultural differences across nation states, with differential ability to impose certain restrictions on citizens. We've seen those differentials across the US states as well. Each of our panelists brings to this discussion considerable expertise to this conversation about international efforts to contain or eliminate infectious disease, such as smallpox, influenza, SARS, examining the role of policymakers, international agencies, scientists, and many others in these kinds of developments, and how historical experiences can help us respond to the current crisis. We'll have about an hour and a half for a discussion today with 5 panelists, each of whom will have 8 minutes to give us their first thoughts on these questions sequentially. And after about 40 minutes of presentation, we'll have a conversation amongst ourselves, followed by responses to your questions. So I encourage you to begin posting questions using the Q&A function at any time during the presentations. Let me offer some brief introductions, at which point then I'll turn it over to the panelists. Peter Baldwin will be first. He's a professor of history at UCLA and global distinguished professor at NYU. He's author of 2 books on past pandemics, Contagion and the State in Europe, 1830 to 1930, and Disease and Democracy, the Industrialized World Faces AIDS, and a forthcoming book in March on the current pandemic, Fighting the First Wave, Why the Coronavirus Was Tackled So Differently Across the Globe. And today, he will speak about how the science of COVID-19 has influenced the public health response. Elena Conis is professor at the University of California, Berkeley in the Graduate School of Journalism and the Center for Science, Technology, Medicine, and Society. Professor Conis's first book is entitled Vaccine Nation, America's Changing Relationship with Immunization. It received several awards. She is currently working on a book on science and the public generally. Prior to joining the Graduate School of Journalism, she was a professor of history at the Emory University and an award-winning health columnist for the Los Angeles Times. Dr. Yanzhong Huang is professor in the School of Diplomacy and International Relations at Seton Hall University, where he directs the school's Center for Global Health Studies, which examines global health issues from a foreign policy and security perspective. He has written extensively on global health governance, health security, public health in China and East Asia. His book, Governing Health in Contemporary China, examines healthcare reform, government's ability to address disease outbreaks, and food and drug safety in China. Professor George Dehner of Wichita State University is a world environmental historian who examines the intersection of humans and disease in the modern era. His first book, Influenza, A Century of Science and Public Health, was published in April 2011 by University of Pittsburgh Press. His second book, Global Flu and You, A History of Influenza, was also published in 2012. And finally, Bob Reinhardt is assistant professor of history at Boise State University, where he works in the field of public health, environmental history, and the history of public health, as well as the history of the American West. He's author of The End of a Global Pox, America and the Eradication of Smallpox in the Cold War, published by UNC Press in 2015. And with that, I will turn it over to each of you sequentially for your 8-minute presentation, starting with Peter.
Thank you very much. I'm very happy to be here in such a distinguished panel. Thank you for having me. What I want to talk about is the science of COVID-19 and how that's influenced the public health response or not. In past epidemics, how the disease in question has been understood has often influenced how it was tackled. With cholera, for example, it was long debated whether it was contagious. Was cholera produced by a transmissible something that passed along by travelers of goods, or was it produced by a miasma that arose from filthy and noxious living conditions? In the first case, quarantining travelers and goods was the solution. In the second case, cleaning up urban filth was. Now, most diseases have had multiple etiologies, so that the supposed science of the illness pointed, in fact, in various and competing public health directions for the tactics that were most appropriate. And it's not just cholera, of course, that fell into this category. Even as late as the early stages of the HIV epidemic in the 1980s, there were debates over the precise cause of AIDS. Was AIDS occasioned by a virus, or were lifestyle issues also pertinent? Now with COVID, scientific disagreement seemed not really to be a factor. The science of the disease was rapidly unpacked. In fact, it was arguably a heroic achievement how quickly its DNA was analyzed. Doing that for SARS, our last major epidemic, took months. With the coronavirus, it took only a few weeks. So how did this scientific uniformity, as it were, uniform understanding of the science of COVID, how did this affect the public health response? Well, you might think that it would mean that the world over the same techniques were employed against the pandemic. Since the science was clear, why would the public health tactics against it have varied? But obviously you'd be wrong. Nations took quite different approaches to tackling the COVID pandemic. In Asia, targeted quarantines were imposed on those who were ill and on their contacts. Most Western nations, however, were unwilling or unable to undertake these sorts of tactics, testing, tracing, isolating the ill and their contacts. And instead, the Western nations had to impose measures that in the aggregate were much more drastic and interventionist, namely, as we've seen, a full-scale lockdown of large parts of the population and much of the economy. And finally, there were a few happy-go-lucky nations that did nothing much at all other than counsel their citizens to avoid crowds and to stay at home. These nations included what were known as the Ostrich Alliance, nations whose strongmen leaders stuck their head in the sand, nations like Brazil, Belarus, Nicaragua, and Turkmenistan. But these nations also included well-functioning democracies like Iceland, the Netherlands, Uruguay, arguably Japan, and most surprising, perhaps, Sweden. Now, these sorts of differences in public health approach did not have much to do with the science of COVID, or even with the political complexions of these various nations. Some leaders thought that they could not make the kinds of drastic demands of their poorest citizens that full lockdown required. But other nations, like the Swedes, thought that their citizens were so well behaved and compliant that they did not need rules and government mandates to do what was expected of them. So the question is, did science play any role here? It did, it seems to me, in a few instances. And one example that I want to talk about briefly is herd immunity. Before there was any vaccine against COVID, herd immunity meant letting the epidemic tear through the population until it had left most people infected and therefore possibly immune to second waves. If you, as a public health authority, imposed mitigation measures, then the pandemic's progress might be slowed enough to prevent the hospital system from being overwhelmed. But overall, the aim was to arrive at broad-scale immunity in the population as a whole. This was the tactic that was followed at first in the UK, and it was the tactic that was followed throughout the pandemic, at least up until the last few weeks, in Sweden. In September, the Trump administration climbed onto this herd immunity bandwagon as well, when it appointed Scott Atlas as a White House advisor, who in the meantime has been fired. But even as they adopted a herd immunity strategy, the political leaders who did so denied that this was what they were doing. And that was for the simple reason that the deaths that were predicted to result from a herd immunity strategy were politically unacceptable. The estimates for this kind of herd immunity strategy were 30 million deaths worldwide, 1 million in the US, 250,000 in the UK, over 300,000 in France. So deaths on a scale that we haven't yet begun even to approach. Mortality on this scale was why the Tory government changed course. It's why the Trump administration did so too in mid-March. But it's not something that apparently troubled the Swedes, whose mortality rates have been consistently 4 or 5 times those of neighboring Denmark and 10 times those of Norway. Both of these other Scandinavian nations imposed quite drastic lockdowns, while the Swedes did not. Now, this so-called science of herd immunity involved faith more than reason. When the decision to pursue this approach was taken, there were no vaccines, there was no evidence that the coronavirus even prompted an immune response. All that came only later. And even today, we don't know whether the immunity, that the vaccines that we now have, whether that immunity is sterilizing. In other words, we know that it prevents recipients from developing symptoms, but we don't know whether these victims are prevented from becoming infectious carriers who still pass on the disease nonetheless. In any case, a belief in the virtues of herd immunity persisted regardless of the science. When antibody tests began revealing that not nearly enough people had been infected to provide herd immunity, proponents of this strategy modified their arguments. They now asserted that not antibodies, but T-cell immunity was what we should be looking for. Or they switched gear and argued that cross-reactive immunity provided by exposure to other similar diseases helped protect against the coronavirus. Luckily for their purposes, T-cell immunity and cross-reactive immunity are hard to measure, and in fact, no large-scale studies have sought to do so. That allowed the herd immunity strategists the appearance of scientific backing without actually having to provide it. They could appeal to a possible source of immunity without having to demonstrate that it in fact existed. Their strategy could thus continue to enjoy a semblance of scientific backing, even though in fact it had none. Asymptomatic carriers without any symptoms, were a similar instance where different understandings of the etiology of coronavirus led to different preventive outcomes. If you thought that asymptomatic carriers were dangerous sources of transmission, and if you also thought that children were among such asymptomatic carriers, then you probably would be in favor of broad and quick testing, since that was the only way of identifying asymptomatic carriers. And you probably also would advocate shutting schools, since that would close down a possible source of transmission. But conversely, if you wanted to keep schools open, and if you wanted to allow people a semblance of normality in the way that the Swedes did, then you had to deny, in the way that the Swedes also did, the importance of asymptomatic transmission, because otherwise your public health strategy was undermined. That was also the reason why, to this day, the Swedes do not require or even recommend masks. They simply deny the importance of asymptomatics and therefore see no reason for masks, since the symptomatically ill are supposed to remain at home and not be out and about wearing masks or not. So the moral of this story is, when the science gets in your way, just ignore it. A few leaders, like Trump, like Bolsonaro in Brazil, a few leaders directly disparaged the advice of the experts. But most other politicians claimed they were following the science, even as they went off in quite divergent directions. So the question is, how was that possible? The science was not clear, nor was it unambiguous in its recommendations. Decision makers could retrofit almost any policy they chose with some sort of scientific backing. Following the science was what politicians claimed to be doing mainly when they were in the process of embarking on risky courses of action that in fact had very little scientific backing. Thank you.
Thank you, Peter. Elena.
Thank you, Peter. Thank you also Keith and Lisa Brady, Debbie Ann Doyle, and Victor at AHA for bringing us together today. I wanted to use my few minutes to introduce two very general ideas from the history of vaccination as a backdrop for thinking about how this history pertains to and sheds some light or gives us some perspective on our current attempts to contain the contagion coronavirus. These two ideas are, again, pretty basic. The first is that vaccines against infectious diseases frame and reframe how we think about those target infections. And the second idea is actually inspired by a colleague's response to a talk that I gave a few weeks ago. This was a colleague who studies the 17th century and whose reaction to my talk was, I didn't know there were anti-vaccinationists in the 19th century. So my second main point is that vaccines and vaccination have always been controversial. They've been controversial since the inception of vaccination and the first instances of its deployment. Before I say a little bit more about each of these points, both of which I could go on about at length, but I'll keep my points very brief. Before that, though, I want to offer a very, very brief overview or timeline of the history of vaccination, one that kind of sets aside for the moment the history of inoculation, the deliberate infection of individuals with infectious disease to complete the course of disease and therefore prevent future infection. Inoculation, you could argue, was the predecessor to vaccination, which, according to the most readily available and widely known and shared historical documents was first advanced in the 1790s. So we are at this point about 225 century years into the history of vaccination. And in this 200+ year history, I think we could look at a kind of couple of points of punctuation. The turn of the 19th century, when vaccination was effective against a single disease. It was used against a single disease, smallpox, which I'm sure we'll be hearing about later in the panel. The late 19th century would be the second kind of moment of punctuation that I'd highlight, when the discoveries of Pasteur and the advent of germ theory gave us a new set of vaccines for both human and animal infections. And then a third point that I'd highlight is the mid 20th century, rather, starting with the development of the polio vaccine and a number of vaccines that were rapidly developed against viral infections after the development of that vaccine. You could add as a fourth punctuation point the turn of the 21st century, which would include the development of the coronavirus vaccines that, as of last week, we now have emergency authorization to use here in this country. But keeping in mind this broad kind of sketch or timeline, I want to zoom in on that mid 20th century moment where we were dealing in the US with epidemic polio that had caused shutdowns that were only a precursor to the types of shutdowns that we've seen in the US today. And I'll be focusing, as you can probably gather, my comments on the US context. The disease and the experience with polio in the 1940s and 1950s was shocking, to say the least, to a country that had actually seen its ability to control infectious diseases and manage their symptoms and their spread improve over the previous half century, you could even say longer than that. But polio also gave us our kind of first real kind of leap of confidence in the 20th century, when we did come up with not just one, but two effective vaccines against it in 1955 and again in 1961. These vaccines were developed thanks in part to tremendous advances and developments in scientific research that began with work to develop a flu and other vaccines in the Second World War. But what these scientific developments did was lay the groundwork for the development of other viral vaccines. And so in the 1960s, in rapid succession, we had several new vaccines against measles, mumps, and then rubella, and other vaccines would later follow. What happened in this moment, though, was that we suddenly had vaccines against human infections that were not considered equivalent to polio or smallpox. And many at the time, in fact, considered these the quote unquote mild diseases. Through a series of events, which I will condense down very briefly, these mild diseases transformed into a category that we now call vaccine preventable diseases. Their vaccines shone a spotlight on these target infections, focusing scientific attention, focusing the attention and efforts of the companies, the pharmaceutical companies that made them and wished to find a market for them, in turn shifting cultural attention onto these infections and amplifying our both cultural and scientific understanding of their complications. These became, within a decade or two, diseases that were known for their severity, for the severe complications. They were known for the urgency of their prevention. And by 1980, they were on a long list of vaccine preventable diseases that in this country, we focused on preventing through the universal mandatory vaccination of children. Now, the reason why I've pointed to this moment is because this was a key moment in which we could see vaccines triggering a process in which they transformed how we thought about their target infections. Mumps, if you look at both scientific and cultural references to the disease in the pre-vaccine era, you'll see one, not terribly much attention, and two, a very lighthearted attitude, as well as a description of this disease as mild. A decade after mumps became the target of mass immunization campaigns, it was never again labeled a mild disease. It was known for the risk that it posed of deafness, among other complications. So this was a reframing of mumps. And in the modern era of immunization, which we could argue begins with polio vaccination, we've seen vaccines reframing how we think about one after another of these infectious targets of vaccines. In some cases, hepatitis B and HPV, this has happened on a slightly different timeline and with more pushback from members of the public who refuse to buy into a broader reframing of these target infections. What we have seen in the case of coronavirus, which I think is fascinating and hopefully can be a point for more discussion later, is the framing of disease as vaccine preventable before we had a vaccine. And I think that there are several reasons why this was the case. One is because it was a disease known for its severity from the start. Two is the state of vaccine science in particular at this point in the early 20th century. And three, on a much longer list, are our modern expectations of biomedicine. And these are in part, of course, directly related to the state of vaccine science, which goes back to the development or research into diseases that we have attempted and not succeeded at preventing via vaccines, such as HIV and SARS and MERS. So had we not framed coronavirus as a vaccine preventable disease, might we have taken in this country different approaches to its prevention? I think that's a question that might be fruitful for some more discussion later. But this question is also related to that other point that I made at the top of my comments, which I'll come back to only very briefly, which is the idea of vaccines as controversial. I mentioned at the top that since we had the first vaccine, the vaccine against smallpox in the 1790s, there have been those who have objected to vaccines, and in particular compulsory vaccination, on the basis of religious reasons, on the basis of fears of vaccine risks, and on the idea that compulsory vaccination is incompatible with the rights and liberties protected by a liberal democracy such as the US. These ideas, in a way, are in extreme tension with the kind of modern faith in biomedicine that leads us to frame a disease like coronavirus as vaccine preventable even before we have the vaccine. And they will also shape how this vaccine is received. And it should be no surprise to us when we do see resistance to this vaccine and what I expect to be eventually its compulsory use in the near and not so near future. I'll leave my comments there and look forward to speaking with and hearing from the rest of the panel.
Thank you, Elena. And I'll turn it over to Yanzhong, but I'll also remind the audience that they can start posting questions at any time.
Thank you, Keith. I'm going to share the screen now. I have to admit that I'm not a historian by training. So if you find what I present seems not to be the typical presentation by historians, please bear with me. So I'm going to talk about the epidemics in historical perspective. You know, as a political scientist by training, I found that this historical epidemics and outbreaks, you know, not only, you know, that can shed light on our understanding of the impacts of the diseases in, like COVID, but can also actually help us to find clues on how to effectively respond to an outbreak like COVID. So, first of all, certainly, right, when we talk about the impact of infectious diseases or epidemics, they have a direct impact, on the this population base, right? One of the best example is how the smallpox, brought by these conquistadors, to the New World, actually led to the reduction of up to 95% of the Native American population. And Black Death certainly might wipe out 1/3 of the European population. And if we compare that to COVID, right, we have, even though when you compare to the Black Death, which led to like 40% of the death of the world's population, right? The percentage-wise, the COVID remains very small. I think if you calculate death by the global population, it's like 0.018%. My friend, the late Professor Andrew Price Smith, who taught at Colorado College, built this model to examine the pathogen's impact on the state. Basically, he looked at two types impact. The first is the direct impact on the state. How epidemic could affect the people who staff the government institutions, including the rulers, the bureaucrats, and the military, and how they could also affect the state's power in international relations. In the meantime, he also, his model points to the indirect effect on the state and by looking at the impact on the society, especially social fabric, economic productivity, state-society relations. And when we look at the COVID, right, we people often talk about how the disease, right, led to the infection of the government leaders, including President Trump, the Brazilian president, etc. Right, historically, right, the epidemics indeed caused destruction of rulers, right? Including Mary II of England, Peter II of Russia, and Louis the 14th of France, and the Chinese emperors too. More recently, right, there's even suspicion that Lenin was also the victim of syphilis, who that might also affect the Russian Revolution. According to Ivan Pavlov, the revolution was made by a madman with syphilis of the brain. So that explains why that the pandemics or epidemics could affect the viability of state institutions. During the 1793 yellow fever epidemic in the United States, the federal governments had to close down. And we saw that the 1918 Spanish flu, right, the way the state institutions actually heavily hit by the pandemic. The social organizations, not NGOs, basically took over in places like Philadelphia. The pandemic also had an impact on the military and warfare. Right, during the plague of Justinian, it actually reduced the size of Justinian's field armies, due to that heavy mortality among young people. And during the Black Death, it had an impact on the warfare because of the labor shortages. It actually led to the formation of mercenary companies, which came to become the mainstay of any army. So they also changed the form of warfare. And the epidemics also had an impact on state power, right? The international relations. We know 2,500 years ago, the plague of Athens, the undermined Athenian power, that was also considered the impact a factor that led to the demise of the Athenian state, And the Black Death shifted the regional balance of economic power. Venice, is essentially reduced into a museum city because of the pandemic. It was the pandemic is even considered one of the significant factors in Spain's decline in the end of the 16th century. And in the meantime, we also have, witnessed we have seen the impact of the epidemic on the society, but through the impact on the economic productivity, social fabric, the pattern of state-society relations. The Black Death, for example, caused a decline in the economic productivity, the flows of the revenue to the state, and that was also in a way documented in the historical literature, including Boccaccio's the book. There's also the historians also recorded the impact on social fabric, right? This is the so-called flagellants, bedlam flooding, and how that could affect the social cohesion, the breakdown of the ordinary routines, the declined confidence in rational theology, delegitimization of existing hierarchies and structures of authority. This is one of the actually major impact is how that is essentially led to the decline of Catholicism as a state religion. The social fabric was badly torn by the revolutionary movements and historical massacres of innocents during the Black Death that also contribute to the migration of the European Jews to Eastern Europe. Right? And finally, we saw how the epidemics could affect the pattern of state-society relations. If you look at, for example, this quarantinist ideology, which essentially was born during some of the societies try to adapt, right? Be cooperative, but the same state intervention also led to the strong resistance from the society, which again, we saw the parallel in the COVID outbreak. To quickly sum up, right, in terms of relationship between the epidemics and the state, it has direct impact through its impact on the government rulers, state institutions, the bureaucrats, the military, and by also affected the state's power in international relations. But in the meantime, it could indirectly affect the state by affecting economic productivity, social fabric, and state-society relations. So with that, I'm going to stop there.
Thank you, Yanzhong. George.
Okay, I'm going to share my screen too as well. Okay. Thanks, Keith, for chairing the panel. I want to thank Lisa Brady for helping put this together and to the AHA for sponsoring it. So I'm going to give a quick overview of influenza vaccine milestones. The key term will be quick, so I'm happy to handle any questions as we come up later. So the place to start is 1933, where we have Smith, Andrews, and Laidlaw discovered that influenza is a virus. And it's interesting how they discovered this. They were working for the National Institute of Medical Research, which was a British government funded operation. But a lot of their funding came from subscribers to a magazine called The Field, which was the magazine for the country gentlemen. And the country gentlemen were concerned about distemper in their dog population. So they were donating money for distemper research, and Smith and Andrews kind of hijacked that a little bit to do influenza research. And they discovered that influenza is caused by a virus, and over the 1930s, they worked on some vaccines, but were largely unsuccessful. The first successful vaccine for influenza was created by Thomas Francis. He was doing it for the auspices of the US Army during the war. This money was funded from the Army. Military recruits received it through after 1943, and it was also offered to the public in 1945. So that breakthrough came in 1943 with US Army financing. The next major milestone is the 1957 Asian flu, and this is really the first attempt to create a protective vaccine to hopefully blunt the impact of a pandemic, but to offer protection to citizens. But in Eisenhower America, there was little appetite for government programs. So this was largely a private operation by 6 United States manufacturers to produce vaccine and distribute it. The role of the government in the form of the United States Public Health Service came in advertising the importance of this particular vaccine and encouraging people to get it. They also offered some suggestions for distribution, but it was really a private operation. 60 million doses were produced. Unfortunately, most of those doses were not available until after the epidemic had crested. So about 30 million of these were unused. In 1968, Hong Kong flu, very similar to 1957. Again, we have 6 United States manufacturers. Again, largely a private operation, crash effort to produce pandemic protective vaccine. 21 million doses produced, and I can't get a more secure figure than the government reporting that a substantial amount were unused. This is the background for the 1976 swine flu decision, which is really a marked change in the way to deal with influenza pandemics, because this was a United States government operation from the beginning. And I've largely focused on the United States up until this point because the United States produced the lion's share of influenza vaccine for the globe, actually. So there were 4 major US manufacturers. The government commandeered with pay. They allotted $135 million for this operation. They commandeered all the production of the 4 US-based manufacturers, and so that they could inoculate every man, woman, and child in the United States, as President Ford announced. This was about, there were about 200 million doses in production at various stages. When the program was halted, about 45 million of these doses were used, which was injected into 31% of the nation in about 10 weeks. So it was a massive operation. It was stopped because of some associations with Guillain-Barré, and also because the influenza virus didn't cooperate and didn't produce a pandemic. This is really kind of a historical artifact, this 1976 event, because the world of influenza vaccine production was changing, and it's nicely illustrated in 2004. 2004, Chiron, which produced roughly half of the vaccine for the American market, had its 48 million doses condemned by UK inspectors at the plant for unsanitary conditions. This left the other major producer for the American market, Venice Pasteur, which produced 55 million doses as the only supplier for the American market. And despite concerted efforts to find new supplies, they really were unable to do so. And so what this Chiron example illustrates, and I want to drill down just a little bit deeper in it, is that Chiron was a California-based company that was producing vaccine in the UK for the American market. Venice Pasteur is a French company which was producing vaccine in the United States for the American market and for other markets. So even though it was being produced in the United States, they had only allocated 55 million doses for the American market, and there was really no slack in the system to produce more. This brings us to the 2009 influenza A H1N1 pandemic 09 virus, which I prefer to call the swine flu. Again, here we have a case of international production. These are global firms producing for the global market, and they produced about 470 million doses. this is government purchase of these vaccines, but a little beyond this purchasing of things on the open market and claims to production methods. The government has no say in what is produced within the nation. It just purchases it on contract. 2015 global production estimates, there are, in 2015, there was an estimate that, or a survey of producers, there were 44 producers around the globe producing influenza vaccine, of which there were 16 major international firms. These companies producing for seasonal markets had the capacity to ramp up for pandemic production, and the estimate was that they could produce 6.3 billion doses in 6 months in case of a pandemic. This leads me to the COVID-19 issue here. And so one component of this is the immense complexity of this vaccine production. This is markedly different than what we've seen in previous cases. There are 61 vaccines in clinical trials at this moment, with 17 in final stages of testing. This is a large number of different vaccine producers producing in a variety of different products targeted at various components of the virus for protection. This makes the example that President Trump illustrates here in his most recent executive order ensuring access to US government COVID-19 vaccines very curious, because in a sense, he's trying to recreate a world that no longer exists. It's really not clear what is US produced vaccines, since these are international companies that are both producing here in the United States and abroad. And I'll just give one quick example. For example, Moderna, which is a US based company and has a US manufacturing base, but they also licensed to produce this vaccine in a number of places around the world, including Switzerland, Spain, and a few other places. So who has command for that is really not clear. And so President Trump's executive order is trying to recreate a world that does not exist. That's my citations if you're interested. And hopefully we'll see this soon.
Thank you, George. And then finally, Bob Reinhardt.
Thanks very much, Keith. I'm also going to share my screen here. And it's a real honor to be a part of this panel with such distinguished company. I want to echo my panelists in thanking Lisa Brady for putting all this together, to Keith Wailoo for chairing our discussion, and to Victor Medina del Toro and Debbie Ann Doyle, and everyone at the AHA for making this happen. Smallpox eradication is kind of a weird topic for comparing to COVID-19 because it's so exceptional in so many ways. It's the first and only deliberate eradication of a human disease in history. It's the oldest vaccine, as Elena mentioned. But I think there are plenty of good reasons to think about smallpox eradication, not the least of which is that it was a success story in the end. And I think we could all use a little optimism and enthusiasm at the end of 2020. I'd like to begin with just a brief description of what smallpox is, or rather was, and what made it suitable for eradication. So smallpox was caused by this little bugger, variola, and the symptoms of smallpox included horrible headaches and fevers, then rash, and then pus-filled and painful bumps. The aftermath was scars, sometimes blindness, but also lifelong immunity if you survived. And smallpox historically had a 25% case fatality rate. Between World War I and World War II, just to give you some other numbers, there were 5.5 million cases and 1.5 million deaths reported, but that was way underreported, WHO said. What made it suitable for eradication is some of the things we've talked about already. It was the oldest and a very effective vaccine. It spread only when symptomatic, and there were no non-human animal hosts or carriers. So in some ways, it was a much more simple situation than what we're facing right now. The story of eradication looks something like this, at least the story that I tell about it in the post-World War II era, the enthusiasm for public health campaigns at an international level. We see smallpox eradication get approved by the World Health Assembly finally in 1958 with a Soviet program. The United States gets involved in 1965 with a bilateral program. with 19 countries in West and Central Africa at the same time that the WHO program starts to expand and accelerate. The CDC's program, US program in West and Central Africa, achieved success by May of 1970 at the same time that the World Health Organization's program was ramping up. And then the last naturally occurring case of smallpox was isolated in 1977, and the World Health Assembly declared victory in 1980. Now, there's a lot going on in this story, but it can really be boiled down to one question. Why? Why did it happen, and why did it succeed in the way that it succeeded? And the question, I think, can in large part be answered by the role of experts, the role of bureaucracy, and the use of low-tech and old-school approaches. Not, as you'll notice, primarily about the virus or the disease itself. So I'm going to jump into those lessons now and how we might think about smallpox eradication in terms of COVID-19. And the first lesson in connecting with Peter's comments is to listen to and heed the public health and medical experts, not the politicians and pundits. During smallpox eradication, by and large, politicians in the United States especially stood back and let the public health professionals do their work. The United States got involved under the Johnson administration, and although Johnson, the administration had a press release, he was not doing daily briefings on the progress of smallpox eradication. Instead, there's only one real photo op from the program that I know of, and it's this one on the right from January of 1968, which celebrated the 25 millionth smallpox vaccination in the CDC's program. And just as a side note, the little girl who was the star of it, Rebecca Ansamoah, screamed through the whole procedure, so they had to find somebody else and get a better shot. But the politicians generally stood back for good reason, and instead they let people like on the left here do their job. So those four folks on the left, this is a great shot and sort of shows them at a lighter moment. George Lythcott was the regional director there of the program in Nigeria. Pat Imperato was a medical doctor working on the program in Mali. He also served for a year as the LA Dodgers physician, as a side note. Bonnie Flanders was the spouse of one of the CDC's members over there, and then Don Millar headed the program from the CDC's offices in Atlanta. And these are the people that made this happen. This was the job for the health professionals. This was their personal and professional passion. It's what they had trained to do and had expertise to do. And it's what their reputation was staked on. And I think that's one of the lessons from smallpox eradication, is to listen to these kinds of folks. Now, I'll be the first to admit that what I'm saying here is an oversimplification, and some of that's because of time, but I think some of it's not too much of an oversimplification. And I'll also admit that I didn't adequately appreciate the role of expertise when I wrote my book. It's actually something that I've learned a lot more about or come to appreciate after watching the highest levels of American government blunder, spin, and politicize this pandemic. That actually brings me to lesson 2, believe in boring bureaucracy. I've got a couple of images here from smallpox eradication. They're not the really sexy images of people riding around on camels or doing other kinds of things, but this is a lot of what made smallpox eradication happen. A 270-page manual of operations that spelled out all of the things that the vaccinators were supposed to do. This map, which is one of a series of 10 maps that Dr. Pat Imperato created as part of a 1.5-year-long study to figure out how to track down different kinds of nomads and be able to vaccinate them. Bureaucracies, organizations like the CDC and the WHO, and bureaucracy paperwork were critical to the success of this vastly complicated and decade-long campaign. And in fact, I think bureaucracy was in many ways a defining characteristic of this campaign. Were there complaints? Absolutely. But more often than not, the system worked. Reports were filed that showed where the disease was so that people trained in appropriate procedures would go to the correct place with the right materials, do the job they had been trained for, and eliminate smallpox. This was supplemented and enabled by ingenuity and on-the-ground adaptation, of course, but still it's an example of bureaucracy doing its job. And I think that's what seems to me underappreciated in our current situation, is that the complexity of this problem, the breadth, depth of the scale, both spatial and temporal, requires bureaucracy, or at the very least, it requires an openness to the potential strengths of bureaucracy. which Americans generally are averse to admitting anything good about bureaucracy. The third lesson that I think I'd like to just briefly bring up is that high tech is great, but there's no school like the old school. As Greg notes, there is justifiably a lot of enthusiasm and excitement and hope surrounding the development of vaccines that prevent COVID-19. And it's truly astonishing how quickly these vaccines have been developed. And during smallpox eradication, there were plenty of high-tech advances and promises that inspired enthusiasm and optimism as well. My favorite is the petojet vaccination gun over there on the left, manufactured by the Scientific Equipment Manufacturing Corporation in New Jersey. It just looks so neat. It looks like a space-age tool designed by the US Army, adapted with a foot pump. But there were other things as well, that other forms of technology that were seen to hold the promise for it, including freeze-dried vaccine. But unfortunately, there were a lot of problems with the technology, specifically with the petojet vaccination gun. Foot pumps leaked, dosage adjustment mechanisms broke, there were chipped seals, lots of other failures. And instead, what it took in the end was a low-tech tool, the bifurcated needle, which you can see on the right, which is really just a needle with 2 prongs at the end that holds just enough vaccine to dab somebody in the arm about 12 times, and then you're done. So that's the tech, such as it was, that was used. And as for the old school approach, what we see happen with smallpox eradication is the embrace of surveillance and containment, as they called it, which is basically looking for outbreaks of the disease and then vaccinating everyone that had contact, surveillance and containment. This had been around since the 19th century, although there were some people in the program who liked to claim more recent discovery of this. This sounds familiar because we call it contact tracing, figuring out who's been exposed and then giving them a vaccine or quarantining them, which was also one of the approaches used during smallpox eradication. And that, not a fancy vaccination gun, is how smallpox eradication happened, through back to the basics epidemiology, through quarantine and vaccination. And so I end with a combination of warning and inspiration. The warnings: without expertise and bureaucracy, smallpox eradication would not have happened. And I doubt that we'll succeed in controlling, much less eliminating COVID-19 without it. And as for high tech, well, sometimes it breaks. Don't depend on it too much and don't oversell it. I want to end, though, with the inspiration that smallpox eradication was an inspiring victory, and that this can be done with a lot of help from bureaucrats, experts, and good old-fashioned disease hunting. Thanks very much.
Great. Thanks, Bob, and thank you to all the panelists. So we'll move into a conversation now, and I will read some of the questions that are coming in to us. Just a few general observations about the talks. We started on a topic of science from Peter, and we actually ended on the topic of science and expertise with Bob, although very different kinds of stories. One having to do with how science, you might say, is that science can, the scientific theories about pandemics, COVID-19, could point in multiple different directions for politicians. And Bob's story is the way in which the smallpox eradication story is one in which the science kind of aligned, you might say, with bureaucracy in service of not just containment, but ultimately eradication, a far more sweeping undertaking. And along the way, we've heard several presentations about vaccines and the way in which vaccines reframe what had perhaps been mild as something more severe, and the pushback that comes, and also the changing, you might say, scale and character and economy of vaccination. That is to say, the infrastructure of production of vaccinations grows over this time period. And then Yanzhong's presentation focused on the challenge that pandemics and epidemics pose for economies and governments and social cohesion more generally. I guess I have a general question about, it seems to me that a lot of the underpinning of many of your presentations is this tension that seems to be part of the COVID-19 story and also part of the history of pandemics between the role of government and the role of private sectors. And you see in the history sometimes a kind of a nice marriage of those two in service of, let's say, scaling up the production. We see at this particular juncture the way in which government resources are really allow for the rapid production of vaccines. So I wondered if you could say a little bit more about this connection, this relationship, this tension that exists kind of not just in the US, but globally between the role of government and the role of private sector in this question of containment. And then the second question I have is really about whether COVID-19 is just the scale of it and the scope and duration is so dramatically different than anything that's really happened in our lifetimes, and what therefore this might mean for the question of containment. That is to say, do the dynamics around containment play out differently now simply because we have been weathering this storm for 10 months? It will likely be another 10 months, I would guess. This is about, I guess, the flu vaccine, the influenza pandemic was a kind of a 16-month story. How does that duration and the scale factor into your thinking about the politics or the possibilities of containment? So 2 general questions, we can chat around those a little bit. Who would like to jump in? Peter, and then Yanzhong.
Yes, I see. Sorry, let me tackle your first question. Private public. Yes, private activity, of course, has been a huge factor in this. Not least the production of the vaccines, though obviously an awful lot of public funding is what has made it possible. But fundamentally, it seems to me that precisely among all diseases, contagious, indiscriminately transmissible contagious diseases are necessarily something that can only be tackled by means of public interventions. All the traditional techniques used against them, whether you're talking about quarantine, isolation, tracking and tracing, all that sort of thing, this is nothing that possibly, the boots on the ground can be private contractors of some sort, but a public mandate of some sort is involved because everyone as a citizen is inherently liable to be put under some sort of duress. And the same even goes for a vaccine. I was struck by Elena's posing of the question, because if I understood it correctly, you were suggesting that a vaccine is a kind of technological fix. In other words, something that is almost a private solution, and that therefore, we don't really appreciate the extent to which it is sort of a public thing. But a vaccine only works if the majority of people have been vaccinated. It's not like putting on a hazmat suit and going out. It doesn't protect you just by virtue of having been vaccinated. Everyone else, or a large percentage of everyone else, has to be vaccinated as well. And so that too is not an individual solution, it's a public solution. And public solutions are inherently ones that require the government to force those who don't otherwise do it to obey.
Great. Yeah, Yanzhong, and then maybe Elena has a response.
Thank you, Professor Walu. I'm sorry, I probably have to leave early because I have another meeting to attend, but I found that your questions very interesting. The first is this question of this containment dynamics, right? It is, I think, it struck me that in a way, we talk about this quarantine measures, right? This is like the response, approach adopted, in Europe, right, when they were dealing with Black Death. That was more than 600 years ago. It was fascinating that after that many years, despite those advancements in biotechnology, right, still that seems to be the most effective approach in dealing with a pandemic like COVID. In China, you have seen how the government was able to use that approach, right, to contain the spread of the virus in a very short period of time. But unfortunately, that same approach, of course, cannot be replicated in many other countries, due to the lack of political will, the lack of state capacity, maybe also other factors, including like religions, so that sort of prolonged, that this process, that we have to live with the pandemic. I will often joke that if the United States, imagine other things being equal, right? That the same approach was adopted in the United States. We don't have to wait for more than 9 months, or being in this pandemic for so long. It probably will just take 2 or 3 weeks, right, to effectively contain the virus spread. So that is one issue. And the second is about the issue of these public-private relationship, right? That you talk about. I found it also very interesting, even like in China, right? That you have basically, the state dominance there, but that relationship between the state and the business continue to be a concern. I was actually a couple of days ago, I published a small piece, talking about this, immunity gap between Western countries, including the United States, and UK, and China after the mass vaccination become possible, because China basically still rely on this, sort of no new infections approach, mass campaigns to deal with, the outbreak. But now with the vaccines become available, right? That poses challenges, because when the U.S. is already have achieved herd immunity, and China still hasn't, right? This is what we call the immunity gap. So you would expect the government is going to focus on the meeting the domestic demands. But in the meantime, you found that is not the case. In fact, I just read the report yesterday saying that the country continued to export the vaccines to the developing world, right? Some of the 3 major vaccine makers, they have received a total like 500 million doses, including actually not just Sinovac is a private company, but even the state-owned enterprises. They're apparently driven by this interest to make money or make profit, export the vaccines. So
Right.
that I found also very, very interesting.
Great, thank you. Elena and Bob, and then George.
Yeah, thanks for those questions, Keith. I think that regarding your question about the government versus the private sector and the relationship between the two in terms of this pandemic, I've been thinking a lot about the parallels between the current moment and the polio era in the 1940s and 50s, and how I think when we approach a question like the one that you just asked, we tend to think of the private sector in terms of primarily, especially at this particular moment when we have 2 new vaccines at hand here, we tend to think primarily about the manufacturers and the private research institutes that have been working on vaccine development. What is so different about this moment relative to the national experience with polio in the 1950s was that the private sector, as it was kind of the one that was most involved back then in response to that pandemic, was actually a private philanthropy, the National Foundation for Infantile Paralysis, which played a huge role in funding research, funding care of patients, and also which played a huge role in making the vaccine and later vaccines available once they were approved for use. And this philanthropy went as far as to agree to purchase large numbers of doses to guarantee the vaccination of the most at-risk population, which was young school-age children. And that's something that's absent in this moment. When we think about the private sector right now, we're thinking about a very different private sector. I also think that the dominance of the private sector in the current moment is part of, in fact, what has framed coronavirus as a vaccine preventable disease before we even had a vaccine. We have tremendous capacity for the kinds of scientific research that has led to the current slate of coronavirus vaccines. And we have, I would say, relatively speaking, a much weaker public sector devoted to public health, especially recently when the strength and authority and financial health of local public health has been whittled away in many places. And so we are left in this moment needing, in fact, to rely heavily on the private sector. But as Peter pointed out, pandemics are public problems. And so they call upon us to turn to government for solutions. And as we're seeing now with current distribution efforts, we will need every level of government to be involved. But it would have been interesting had that been more of the approach early on.
Great point. The impoverishment of our public health system is the backstory to where we find ourselves at this moment. Bob, and then George, and then I'll turn to the Q&A.
Great. I wanted to spin off of what Elena was saying about thinking about COVID-19, framing it, conceptualizing it as a vaccine preventable disease, which I think is so smart. And for me is so striking in relation to the question that you posed, Keith, about the scale, scope, and duration of COVID-19, where what I was hearing you say is, man, we've been in this for a long haul. And my reaction as somebody who studied smallpox eradication is like, we have unrealistic expectations about how long this sort of thing takes, you know, from zero to vaccine in less than a year is incredible. And I think one of the problems that we're in right now are that people expect not only have expected from the beginning, how fast can we get through this? And by getting through this, we mean total and complete elimination of COVID-19 as a problem. Like, I mean, I know there have been some public health officials and other medical experts who have said, you know, we're in it for the long haul with this. Things are not going away, but that is all background noise. Nobody seems, and if you look at newspapers, all they're talking about is the vaccine is at hand. We're going to get through this. Everything's going to be great, and we'll be back to normal. And I think one of the problems we're in right now is that these expectations about time are far too brief. Expectations about results are far too extreme. And smallpox eradication, just as an example, the program in West and Central Africa, which was relatively low-hanging fruit for the CDC, for a variety of reasons, they had originally planned on that being for 5 years, that taking 5 years. It took 3, and they basically used all the champagne at the CDC's offices in Atlanta to celebrate how quick it took, 3 years. And here we are a year into this saying, why aren't we done with it yet? And I think that's going to cause some real problems and some real public health professional messaging issues.
Interesting. George.
I want to address both questions and follow up what Bob said there. But first, I just want to, one of the examples we use about government and private industry and how they work in harmony. And there's a lot of examples of private industry not necessarily working to the goals that the government wants in the way that they want, right? So private industry has, they operate in a different universe. They're a universe of profit. And public health is about protecting the public, right? So there's differences there, and they play out. But I also want to think about it, even when an example of when private industry is trying to pursue something that benefits the public, but because it wasn't as well integrated with government operations, it wasn't completely successful. And I was thinking about Merck's distribution of a pill to protect against river blindness. Now, this pill is highly successful, and they produced it and largely distributed it free to governments to give to their population to eradicate this disease. It was seen as charitable work by Merck, but the effort was frustratingly unsuccessful for a long period of time because it wasn't harmonized with how the public response wanted it to work. So there was a technical solution, but it didn't factor into how this would operate in the places where river blindness was occurring. So even, private industry has to work with the government, not just the government working with private industry, I would say. And so on this issue of containment, to follow up on what Bob is saying about, the length of time, I think we have to think about what we are terming containment here. My concern is just the structure of this particular virus and how efficient it is and insidious a transmitter it is when it's given the opportunity, that I'm afraid this is going to be around for a while. And so it's not going to be containment where we're walling it off into a certain area and we're safe behind our barricade of vaccines, but it's something that's going to be insidious that is going to need management on a global scale, right? In which, resistance to vaccine in the United States may make us one of those places where it continues to circulate and a threat to other nations. So thinking about containment, I think we need to think a little bit about what do we mean by containment?
Very good. So let me pose about 3 kinds of questions that have come in, and some of them are a little lengthy, but I'll try to get through them. But we have many more than 3. I'll start with Hillary Smith, who has posed 2 different kinds of questions, but the first question from Hillary Smith was a question connecting Professor Baldwin and Professor Conis's talks. I'm wondering if the different COVID paths of different countries reflect more than just politicians' desire to find science that justifies their already chosen policies. I wonder if it has to do also with the relative prestige of different kinds of sciences in those countries. Here in the US, for example, laboratory science seems to have a lot of prestige. Epidemiology, not so much. So we hear a lot about vaccines as the solution, but not so much about testing and tracing, quarantine, masks, despite evidence that the latter can work really well. This question emerged in my mind because of Professor Conis's point that this is the first disease framed as vaccine preventable, even before it was vaccine preventable. Why would we frame it that way unless we thought salvation can come through a laboratory? Then Jane Bowl poses 2 kinds of questions. One is very simple but difficult to answer because it asks us to be something of futurists rather than just historians. If it is possible to say, how long does the panel see this pandemic lasting? How will it be eradicated? And that is really asking you to, take your historical insight about eradication or containment and apply it to this particular example. And secondly, what does the panel feel are the greatest dangers that we face as a society? Another question from Margaret DeLacy, it's just a comment. I'd argue that surveillance, this is to Bob Reinhardt, I'd argue that surveillance and containment date to the early modern period, not necessarily to the 19th century. We can put that, you can deal with that if you'd like. And then finally, I'll read Sherry Gould's question. Can anyone speak to reestablishing trust when it comes to vaccination and particularly marginalized communities? I liked what Bob had to say about the alignment between science and bureaucracy, but there is a long history of mistreatment by both these entities. How can this be remedied? Can it be remedied? So lots to chat with. So I see Bob's hand went up and then Elena.
Yeah, so first of all, in response to Jane's question, actually, pardon me, I'll start with Margaret DeLacy's question, great, about the origins of surveillance and containment. Yeah, you're absolutely right. It's got much earlier origins. My reference to the mid-19th century was specific in relation to approaches to smallpox in the published medical literature. So when people in the CDC were saying, let's transition to surveillance and containment, and In particular, one guy, William Fagey, who's gone on to do a lot of great work and getting a presidential Medal of Honor, saying, we came up with this. Others have said, actually, if you look at the smallpox literature, they were doing this in the mid-19th century. But you're absolutely right about it having been done much earlier. So thanks for catching that. To Jane's question about how will it be eradicated, I'm afraid the answer is it won't. I think that that's far too complex of a disease, as George was getting us to think about, starting with the fact that it's got non-human animal hosts and other carriers that are probably involved in it. And the level of complexity with COVID-19 is just, I think, to the point where we're not going to be able to eradicate it. If we think about the only disease we have successfully, human disease we've successfully eradicated, it's relatively simple. And I think that that's going to pose a real problem for us. So I'll answer those two questions and then back away.
Great. Elena.
Thank you. Those are all fantastic questions, and I too will try to answer them briefly. With respect to how long will this last, I want to echo Bob's point that I don't think we can be talking about eradication, and we should be talking about control, which is essentially the topic of our panel today. The two diseases that come to mind when thinking about how to think about this particular disease are plague and measles. Plague is not at all eradicated, but it is exceptionally well controlled. However, it also, as Bob just mentioned, it's one of these diseases that has non-human hosts. And I wrote a piece a few months ago about how plague can urge us to think about what it means to contain coronavirus in a human population when it very well may find non-human reservoirs that may very well still prevent the risk of infection 500 years from now. So we should be thinking not in terms of a year, 2 years, or even a few decades, but possibly even centuries with this disease. But the other disease that this brings to mind is measles. And measles too is a disease that we've lived with for millennia, is relatively well contained through vaccination, but as recent years have shown us, epidemics and outbreaks are still possible. And I've read a few scientists' opinions that measles may be one of the best models we have for coronavirus at this point, that a really good scenario would be having this relatively well controlled, in a decade or two, but having to deal with sporadic outbreaks like we do with measles. In terms of reestablishing trust, I would just very briefly say that we have always struggled to maintain trust across all segments of population targeted with vaccines or vaccination. And distrust of vaccines and vaccination, I also believe, is a symptom of distrust in authority, expertise, and political figures. So I think that I could go on at length about that, but I just want to emphasize that I wouldn't think about this in terms of reestablishing it, but figuring out how to live with persistent elements of distrust. Somebody had also asked the very interesting question of, did we frame coronavirus as a vaccine preventable disease because of the prestige of laboratory science? I love this question, but I want to add in liberty. And I think that liberty has a lot to do with how we've framed coronavirus. Vaccines, when mandatory, infringe upon liberty, but so far our best attempts to control coronavirus have involved other infringements, immediate infringements of liberty, such as mask wearing and shutdowns of businesses and local places of gathering and schools and so forth. So I think there's a really complex answer to that question, which I wish I could do better justice to in the short amount of time, but I'd be happy to communicate with that person over email. Thanks.
Great. So I see Peter and George.
I'll go first. I don't quite remember who asked a specific question, but one of the themes behind the questions was this question of this issue of vaccination as a kind of technological fix to a political problem. And if we didn't have a vaccine, we'd be forced back to simply the politics of traditional public health measures, fundamentally quarantining and isolating people. And in those terms, of course, the gorilla in the corner, the elephant in the corner of the room is, why have democracies done so poorly, with a few exceptions like New Zealand and Australia? Why have they done so excruciatingly poorly compared to the countries above all of Asia and containing it? And we're going to be discussing this endlessly for years to come. And the simple solution is that a lot of people resist because there are civil rights infringements and that sort of thing. I think, in fact, it's to some extent the opposite, that enormous numbers of people were quite willing to submit to the lockdown that was imposed on them by their governments, but that actually the political leaders distrusted their citizens and didn't realize that they could have, in fact, imposed much further lockdowns and much longer lockdowns than they did. But that's an issue we're going to discuss endlessly. My point is mainly that, of course, the democracies are particularly interested in a technological fix because it gets them out of a political problem they've proven themselves to be rather incapable of solving. On the other hand, the Chinese, who solved the political problem insofar as they had one, because they have stronger measures and stronger powers that they can enforce, of course, are equally interested in the technological fix of the vaccine. And they're now, in the vaccine producing league for the first time, wanting to play with the other nations. And so they're obviously not, why drop a tool in your toolbox that you don't have to? One very quick response to the question about trust in vaccination. I'm less fussed by that, I think, in a big picture, because if you look at confidence in vaccination, it correlates very positively with poverty and sort of hard circumstances in general. Trust in vaccination is, deep into the 90s, people having trust in vaccination in the global south. The least trustful nation on earth in vaccination is France. If you look at public opinion, more kids are vaccinated, a higher percentage of kids are vaccinated in New York public schools than in New York private schools. Anti-vaccinationism has been until recently a sort of a malaise of the posh. And it's only sort of recently, and in certain, I think, quite limited communities, that it has also become sort of something that the poorest among us, who know perfectly well, when they think about it, that they stand to benefit most from this because they have the fewest other means of resisting disease. I don't think in the long run this is going to be a huge issue. Once the advantages of being vaccinated become clear, I think most everyone is going to sign up.
Great. So George, and then I'll try to go to one more round of questions. I'll throw one in for myself.
Okay, so I'll speak to two things. Thanks everyone for the questions, by the way. They're really thoughtful questions. I'll pick up on the trust thing and then jump to this issue about the approaches for the different kinds of sciences. The trust issue, there's really two questions here, I think. So marginalized communities, how do we regain that trust? That's a very tough issue. Both issues about regaining trust are hard. This one is the hardest of the two because it has been a failing of public health here in the United States for a while, and for good reason, right? There's certainly a track record of unfortunate events in which people should not have trust in marginalized communities about the approaches. So that's an issue that I really don't have a good answer to. But in the short term, so if we're thinking about this COVID vaccine, there is a model not too long ago, which I found to be very successful, which could be easily replicated and would begin the process of gaining trust back in this process of vaccination. And that's the method that was used in 2009. So the 2009 pandemic response, there were influenza experts who spoke every day to members of the press for hours at a time, fielding all sorts of questions. And then those answers were posted on social media. And they were also posted on the CDC website for anybody to go and listen to. It's not perfect by any stretch. You're never going to reach people who don't want to be convinced. But in terms of wild theories that are flying about that are addressed immediately by experts and then posted for everyone to have access to, that's a very persuasive mode of gaining trust in the system. It's clearly not a system that's been utilized right now in the United States. We'll leave it at that. The issue about different kinds of sciences I find very interesting, and I think back to the United States response in terms of influenza. Coming out of World War II, the United States and its impact at the World Health Organization, the United States has focused upon technological issues from the World War II going forward. That really has been the approach that the United States has funded and followed. It remains to some degree a favored tactic, not only by the United States, but certain NGOs like the Gates Foundation. They approach technical solutions. There's a lot of, you have the outcomes that Bob has talked about. The eradication of smallpox is to some degree a technical, here we're talking about the bureaucratic experts, but it's a formalized technical approach to solving this problem of smallpox. So it has a long history in the United States of funding these efforts, both domestically and international forums.
Great. So there's one other model of a recent sexually transmitted disease that we might throw into the conversation as a way of thinking about possible trajectories, and that is HIV/AIDS. That is to say, the dream of a vaccine never realized, but what we have done is through medical science and therapy transformed it into a chronic manageable disease, not for everyone, but which is another trajectory for how one does containment using the tools of science and medical care, but without actually eradicating the disease, and in fact, not necessarily cordoning off either. So this mixture of kind of public health, individual kind of behavior change, as well as kind of medical science transforming the trajectory. So I'll leave you, we have 3 minutes left, but I'd like to maybe have 3 other questions circling around, and then maybe have you just quickly answer. Caitlin Sullivan asks, I'm interested in misinformation and whether any of our panelists see any parallels to the past in today's rhetoric about the vaccine. Oops, my screen keeps changing here. Somebody made that question disappear before I was able to ask it, sorry. That wasn't very good. Okay, John Carranza says, whoever is controlling that, please don't do that again. Americans' reaction to COVID fell, at least on the surface, along political party lines. How do we reimagine our role as historians to parse false information, instill trust in experts, and really show that pandemics are slow to resolve? And then finally, a question from Ashley Bowen, along the lines of the question of duration. I'm curious about how we've identified endpoints in pandemics. At what point do we describe a pandemic as over, short of the kind of eradication of disease? What does identifying an endpoint reveal about the response? So we have a few minutes left. Maybe if any of you would like to throw in some final comments to these terrific questions. Elena.
I'm happy to just throw in some rather superficial thoughts, but in terms of endpoints, I think that we get to decide when this is over. And historically, I think if we want to take a lesson from the past, it's when the disease has gotten to a point where it no longer rules how we live our lives, to the extent that it does now. It likely will, possibly in the form of ongoing testing or ongoing vaccination or treatment, but it won't be ruling our lives, hopefully, to the extent that it is now. And that's probably how we'll define the endpoint in this case. There are so many parallels to the use of misinformation today in the past. But rather than dwell on those, what I'd rather do is point out something and echo something that Peter mentioned a little bit ago, which is that actually faith in these preventive measures is higher than we usually give credit for. And faith in vaccines and vaccination is actually higher than we usually pay attention to or acknowledge. And that gives me, to go back to Bob's point, some confidence and a little bit of optimism that even in the face of misinformation, we will be able to use whatever tools we have effectively enough over time.
Mm-hmm.
Can I just
Peter?
one little tiny factoid to add to that? Flu vaccination take-up has gone up during the COVID.
Yeah, I think that, one of the interesting things that we talk about, and maybe this goes back to Yanzhong's comment, which is he emphasized in some ways the economic calamity that the pandemics are, but they're also, as many of you have pointed out, they're opportunities. There are certainly economic opportunities created by pandemics. We're using one of them right now, remote conferencing, as a way of creating community, which is likely to outlast the pandemic. Peter just referred to the uptick in immunization. That is to say, there's one other thing that happens in the course of pandemics, which is the opportunity to remake these kinds of relationships anew, or to make relationships anew. One of them potentially being the recreation of a public health system that is up to the task of actually doing the kinds of things that societies have been able to do in the past in the wake of these dramatic threats. So let me end by acknowledging that Mercia Renew had a question. Elena is one of an undergraduate student from your class at Berkeley in 2007, which was very impactful, she says. Also loved your book, and her question to you, which you can tackle offline, is it builds on your last remark. In her view, the vaccine is a techno-utopian silver bullet underpinned by both the extreme and unprecedented lockdown response and Trumpian selective apathy. Do you agree? How else might the idea of the imminent vaccine have affected the response? And then there's a question by Gary Shea, a comment, some CARES Act benefits, example, Medicare carries mandatory coverage of telemedicine and COVID-related services expire when the COVID crisis ends. And then Sarah Naramore notes that she's curious about the panel's thoughts on the role of testing in the containment of COVID-19. Like some other epidemic diseases, yellow fever comes to mind. Mild cases are so generic in terms of symptoms that they are difficult to identify clinically. It strikes me that testing is a fairly new tool for public health, and one that can be either extraordinarily useful or problematic if poorly implemented. How can we contextualize the meaning of testing historically? And so with that, we've actually made it through we don't have time to answer those questions, but I thought I would pose them and have them ring in your ear, maybe for the next time we gather. I'd like to thank you all, including Yanzhong, for this just wonderful series of presentations and an incredibly rich and to some extent optimistic, forward-looking discussion about the path that got us here, but also the path ahead. Debbie-Ann, I didn't know whether you were going to come back again to make some final comments to those who are gathered.
Yes, I would just like to thank everyone for joining us today for a very excellent discussion. A recording of this webinar will be on our YouTube channel soon, and you can also view recordings of past virtual AHA events on our YouTube channel. I'll put in one last plug for our next webinar, History and Historians in Response to COVID-19, Infection and Inequality, which will be on Wednesday, December 23rd. At noon, and we'd like to again thank our generous sponsors, the National Endowment for the Humanities, the Stanton Foundation, the History Channel, and Oxford University Press. Thanks to all who submitted questions, and finally, a special thanks to the panelists. Thank you.
Thank you. Thanks, everyone.